So this is our last topic for this course about pediatric neurologic disorders. As a review, the neurons, the cells of the nervous system, are unique cells which consist of a nucleus and its extensions, one axon and several dendrites. Its function is to transmit impulses to and from the nucleus and other body organs. The central nervous system consists of the brain and spinal cord. The peripheral nervous system consists of the cranial nerves and the spinal nerves. Accessory structures include the skull, vertebral column, meninges, CSF, to name a few. So you have to recall the central and peripheral nervous system, its accessory structures, its parts, and the functions. A complete neurologic test is essential to identify different neurologic deficits. A full examination has 6 areas to be assessed, which are the cerebral function, the cranial nerve function, cerebellar function, motor function, sensory function, and the reflex testing. I expect you to recall this neurologic examination as you have learned from your health assessment or HA course. Also, a variety of diagnostic tests may be ordered to provide more information should any abnormalities be detected in the health history, physical examination, or neurologic examination. First is the lumbar puncture. It is the aspiration of CSF in the lumbar area for analysis. Second is cerebral angiography, CT scan, MRI, or skull X-ray. This visualizes the brain. Third is myelography. This test is to visualize the spinal cord. And fourth is electroencephalography or EEG. This test measures the electrical activity of the brain. So box 49.2 shows a child with signs and symptoms of different neurologic disorders. All throughout our discussion, we will be tackling these different signs and symptoms. So these are the different neurologic disorders that we will discuss. First is hydrocephalus. It's the increased amount of cerebrospinal fluid or CSF within the ventricles or the subarachnoid space of the brain. If the infant whose cranial sutures have not firmly knitted, this excess fluid causes enlargement of the skull, which is shown as an enlargement of the head. Normally, recalling the physiology, CSF is produced by the choroid plexus. It travels within the brain, then it is absorbed in the subarachnoid space of the meninges. These 3 pathways, from the moment it was produced up to the moment it was absorbed, are also the usual pathways or causes of hydrocephalus, which is first, overproduction from where it is produced in the choroid plexus. Second, there could be a possible obstruction during its travel from the point of origin to the point of absorption. And third, there is inadequate absorption in the subarachnoid space. First classification of hydrocephalus is whether it is intraventricular or extraventricular. Intraventricular or obstructive is when the flow of CSF from the ventricles to the subarachnoid space or from the moment it was produced to the moment it should be absorbed is obstructed. Examples of these is when a child has tumor. Second is extraventricular or communication. Flow is not obstructed during the travel, but CSF is inadequately absorbed in the subarachnoid space and reaches the spinal cord. An example of this case is when the child has meningitis. The subarachnoid space is within the meninges. Another classification is whether the child is congenital. The hydrocephalus is congenital or acquired. Congenital occurs at birth. Its cause is generally unknown, although maternal infection may be a factor. Acquired is from an incident later in life. It could again be from meningitis, brain tumors, as mentioned earlier, also head injury, and other possible causes. Box 27.3 shows assessment findings in an infant with hydrocephalus. These symptoms may either develop rapidly or slowly depending on the cause. Enlarged head size, the fontanelles are bulging, non-pulsating, wide, and appears tense. Suture lines separate, scalp is shiny, and the veins are very prominent. The eyebrow bulges forward. There is sunset eyes or downward rotation of eyes. There's poor feeding, vomiting, lethargy, irritability. The cry is shrill and high-pitched. There's an abnormal muscle tone, and what we need to check the most are signs of increased ICP. For the diagnostic tests, the above photo visualizes excess CSF, as evidenced by the more darkened color. A CT scan, MRI, and X-ray can show this, and they can also reveal separating sutures and thinning of the skull. Figure 27.9, the photo below, shows another test, which is transillumination. It is holding a bright light, such as a flashlight or a specialized light, against the skull in a darkened room. These will reveal that the skull is filled with fluid or CSF rather than the solid brain. Management. The treatment of hydrocephalus depends on its cause and extent. If cause is CSF overproduction, acetazolamide or Diamox can be given to promote excretion of excess fluid. This drug is a diuretic. Second is through ventricular endoscopy, shown in the photo above, which can destroy a portion of the choroid plexus, where CSF is believed to overproduce. This procedure is creating an opening into the ventricles using an endoscope through a borehole. Third is removal of tumor in the area if it is responsible for CSF overproduction. This could be through craniotomy. The tumor compresses the choroid plexus and causes the increased CSF production. So if tumor is removed, the area will be relieved of compression and will not produce excess CSF. The other groups of management is if the cause of hydrocephalus is obstruction. Laser surgery can reopen the route of flow. This uses laser beam to cut tissues. The fifth one is the most common management for hydrocephalus, which is ventriculoperitoneal shunting or VP shunting. This procedure is shown in the photo below, figure 27.10. This is the bypassing the point of obstruction in the ventricles to the point of absorption in the peritoneum. This involves insertion of a thin, flexible catheter under the skin from the ventricles to the peritoneum. The shunt drains excess CSF from the brain, and that fluid is absorbed by another organ, which is the peritoneal cavity. This catheter has to be replaced as the child grows old, or it will become too short and cannot absorb CFS anymore. Other than that, the child will show again signs of increased ICP, which means the shunt is not functioning anymore. As another complication, since there is an implanted foreign body, it can become infected. So watch out for those signs, also signs of peritonitis. Last is ventricular endoscopy again. It's an alternative to VP shunt. These can relieve obstruction within the ventricles. As of now, this procedure is being perfected, so maybe the next generation of hydrocephalus won't need VP shunts anymore. Unlike in VP shunt, there is no implanted foreign body in ventricular endoscopy. Second is neural tube disorders. These disorders occur when there is lack of fusion of the posterior surface of the embryo in intrauterine life, particularly the neural tube. As a review, the neural tube forms in utero first as a flat plate and then molds to become the brain and the spinal cord. The incidence of neural tube disorders has fallen dramatically in the recent years. This is because of better maternal nutrition now, especially a diet that is sufficient in folic acid, about 600 micrograms daily. This appears to be a major contributing factor to prevent neural tube defects. So what are these different neural tube disorders? Anencephaly, microcephaly, spina bifida occulta, meningocele, myelomeningocele, and encephalocele. These disorders may be inherited, so the risk of bearing a second child with a neural tube disorder once one child is born with it increases. First is anencephaly. This is the absence of cerebral hemispheres. It occurs when the upper end of the neural tube fails to close in early intrauterine life. Children cannot survive this disorder because they have no cerebral function, and we all know that the respiratory and cardiac centers are located in an intact medulla. During labor, these newborns may have difficulty because the underdeveloped head does not engage fully in the cervix. Many are also in a breech position. These newborns may either be born dead or alive. If alive, they may survive only for several hours or a couple of days. In my several years of being a neonatal ICU nurse, caring for these babies are the most heartening for me because nobody can save them and you just wait for them to die. But while still alive, these babies must be given basic care, such as feeding them and putting clothing on. In other countries, parents may opt for therapeutic abortion because it's legal in them. Once anencephaly is diagnosed prenatally, but other parents elect to carry the fetus to term for the purpose of giving the child's other organs to be used for transplant. As a diagnosis, there's elevated level of AFP in the maternal serum or also an amniocentesis, and prenatal sonogram reveals the absence of cerebral hemispheres. Microcephaly is a disorder in which brain growth is so slow that it falls more than 3 standard deviations below normal on growth charts. Generally, this infant is cognitively challenged for life because of the lack of a functioning brain tissue. Causes are either intrauterine infections such as rubella, cytomegalovirus, or toxoplasmosis, and there could also be severe malnutrition or anoxia in early infancy. The fontanelles, which close early, shows bossing of forehead and signs of increased intracranial pressure similar in hydrocephalus. Normally, the anterior fontanelle closes in 1 to 1.5 years, while the posterior fontanelle closes in 2 to 3 months. This condition must also be differentiated from craniosynostosis, which is the normal brain growth but premature fusion of cranial sutures. Hence, there is a small head circumference. With surgery, craniosynostosis can be relieved and brain growth will be normal. Spina bifida occulta occurs when the posterior lapinae of the vertebra fail to fuse. It is most common at the 5th lumbar or the 1st sacral level, but may occur at any point along the spinal cord or the spinal column. The term spina bifida alone is often used to denote all spinal cord anomalies. This is a serious disorder, but spina bifida occulta is not. If with the word occulta, the condition is benign. So this is a benign disorder of failure because the vertebral arch failed to fuse. Remember that the spinal cord and the meninges remain in normal anatomic position. So it's just the bone which covers them that is defective. The defect may also not be visible, or it may be identified by a simple tuft of hair or a dimple on the spine, as shown in the photo. The child is usually asymptomatic or may have slight neuromuscular defect depending on the severity of fusion failure, whether it hits either the spinal cord or meninges a little, but it is rare. Generally, there is no need for surgical correction, but some children may eventually need surgery to prevent vertebral deterioration because of unbalanced spinal column or vertebral column. Meningocele is when the meninges, filled with spinal fluid, protrude through an opening in the spinal canal, usually in the lumbar region, although this might be present anywhere along the spinal canal, as shown in the photo. It appears as a protruding mass, usually the size of an orange, at the center of the back, either covered with skin or only the clear dura mater. The spinal cord is intact and there are no nerves in the sac. Because of this, no motor or sensory function is lost. As a treatment, immediate surgery within 24 to 48 hours is needed to replace the contents that are replaceable and to close the skin disorder to prevent infection. Surgery involves many risks. The loss of meninges removed by surgery may limit CSF absorption, resulting to hydrocephalus. Myelomeningocele, on the other hand, involves the protrusion of both the spinal cord and the meninges through the vertebra, as shown in the photo. Compared with meningocele, in meningocele, only the meninges protrude and the spinal cord is intact. Since spinal cord is affected, motor and sensory function below the level of the lesion is lost. This is how we can differentiate myelo from meningo because of the neuron damage. Because by just looking at the lesion, it is impossible to tell whether the inside includes just the meninges or both the meninges and the spinal cord. Assessment findings: CT scan, ultrasound, or MIR will confirm diagnosis. But without the diagnosis, you can differentiate myelo from meningo because of the affected motor and sensory function, again, below the level of the lesion, which are lower extremities are flaccid, they cannot move and lack sensation. There could be loss of bowel and bladder control. Urine and stools continually dribble because of lack of sphincter control. And they have talipes or clubfoot disorders and have developmental hip dysplasia. Fifth one, hydrocephalus, both can be seen in myelo and meningo. Treatment in myelomeningocele is similar to meningocele and involves the same risks. Parents need a great deal of support because their child has multiple challenges. These parents need to know that even after surgery, the child might have paralysis of lower extremities and loss of bowel and bladder function still because the absent lower cord cannot be replaced. Encephalocele is a cranial meningocele or myelomeningocele. This occurs most often in the occiput area of the skull. It is either open, covered by dura, or covered by skin, as shown in the lower photo. Again, it is difficult to tell if only meninges have protruded or brain tissues are also involved. The risks is very high, especially the risk for hydrocephalus. Tests include transillumination of the sac, which will reveal solid substance or a fluid inside. There could be a test to reveal the size of the skull disorder through CT scan, MRI, or ultrasound. Again, treatment is similar to meningocele and myelomeningocele and involves the same risks. And due to brain involvement, in encephalocele, the child may have limited cognitive potential. Reye syndrome is acute hepatic encephalopathy associated with swelling of the brain and the liver. It also involves fatty infiltration of many organs such as liver, heart, lungs, pancreas, and the skeletal muscles. It's common in 1 to 18 years of age, whether boys or girls. The exact cause is unknown, but child appears to be recovering from a viral illness such as varicella or influenza, during which aspirin has been given to them 3 to 5 days later. Because of this, teaching parents to avoid aspirin during viral infections is important, and this has led to almost total prevention of this syndrome. Assessment findings: after seeming to recover from an initial viral illness, children become ill again 1 to 3 weeks later. They appear in stages. Stages 1 and 2. Symptoms in adolescents may be so extreme that they mimic those of drug intoxication. For stages 3, 4, and 5, cerebral symptoms progress from too much pressure on the brainstem. Diagnostic and laboratory tests. There are elevated liver enzymes, ALT, AST, ammonia, amylase, BUN, fatty acids, and WBC. There's delayed PT and PTT. There is low blood glucose. Lumbar puncture can be done to rule out if there is infection. Skull, X-ray, CT scan, or ultrasound can show edema and decrease ventricle size, and the liver biopsy will show fatty infiltration. If left untreated, Reye syndrome is rapidly fatal, but if diagnosed early and promptly treated, however, the child usually recovers quickly and without any residual neurologic effect. So therapy is directed toward supporting respiratory function, controlling hypoglycemia, and reducing brain edema. This is not infectious. Treatment is supportive based on the stages of involvement from stages 1 to 5. Cerebral palsy or CP is a group of non-progressive disorders of upper motor neuron impairment that results in motor dysfunction. It's a permanent movement disorder that appears in early childhood. These are the associated problems: mental retardation, hearing loss, defective speech, dental anomalies, orthopedic problems, visual disabilities, seizures, or hyperactivity. Again, a child with CP may just have these associated problems, but what is usual or what is common among CP children are the motor neuron problems. Etiology: the exact cause is unknown, but apparently it's caused by brain anoxia leading to cell destruction of the motor tracts either during intrauterine life or during delivery. This is associated with low birth weight, premature birth, SGAs, placental problems, problems during pregnancy such as lack of nutrition, substance abuse, and infections. Upon birth, it may be caused by child abuse, shaken baby syndrome, trauma or dehydration, and child infections such as meningitis, encephalitis, and hyperbilirubinemia that is untreated leading to kernicterus. There are 4 types: spastic, dyskinetic or athetoid, ataxic, or mixed. Spastic type. Spasticity is excessive tone in the voluntary muscles. Approximately 40% of CP children have this type. It's also called pyramidal cerebral palsy. The other 3 types are called extrapyramidal cerebral palsy. A child with spastic CP has hypertonic muscles, abnormal clonus, exaggerated deep tendon reflexes, abnormal positive Babinski, tonic neck, and parachute reflexes. Continuation of neonatal reflexes well past the age at which these usually disappear is usually present or seen. Also, these children assume a Caesar's gait because the tight adductor thigh muscles cause their legs to cross when they are held upright. This problem can lead to subluxation of their hips. Also, there is tightening of the heel cord. It is usually so severe that children walk on their toes. They are unable to stretch their heel to touch the ground. They cannot walk in coordination. Spastic involvement may either affect both extremities on one side, which is hemiplegia. There is a greater involvement in the arm than the leg. There's also difficulty identifying objects placed in their involved hand whenever their eyes are closed. You call it asteriognosis. And hemiplegia children from spastic type CP usually is associated with this asteriognosis. Second is involvement of the all four extremities, quadriplegia. There is impaired speech. Usually, you call it pseudo-bulbar palsy, but may or may not be cognitively challenged. Swallowing is also difficult for them, so they drool. The upper extremity involvement may be limited to abnormal, and there is awkward hand movement. The last one is the involvement of the both lower extremities, diplegia or paraplegia. Since here there is no upper extremity involvement, spinal cord anomaly rather than a cerebral anomaly is suggested. Dyskinetic or athetoid type of cerebral palsy. Dyskinetic means there is a disordered muscle tone, while athetoid means worm-like. It is generally characterized by abnormal, involuntary worm-like movements. Early in life, the child is limp and flaccid, but later on, in place of the voluntary movement, children make slow twisting motions. It involves all four extremities and may extend up to face, neck, and tongue. This type of CP is also associated with deafness caused by kernicterus. Also, whenever the child is in emotional stress, the involuntary movements become irregular and there is sudden jerking movement or the choroid movement. Because of poor tongue and swallowing movements as well, the child drools and speech is difficult to understand. Ataxic type. Children with ataxic involvement have an awkward wide base gait as shown in the photo. On neurologic exam, they are unable to perform the finger to nose test as well as the rapid repetitive movements. Ataxia is a loss of balance. So this involves testing the child of cerebellar function such as balance and coordination. Mixed type. In mixed type, some children show symptoms of combination damage. It's either there is spasticity and athetoid movements or ataxic and athetoid movements. This combination results in a severe degree of physical impairment. Table 49.4 shows the physical findings that suggest cerebral palsy regardless of the type. There's delayed motor development, abnormal head circumference, abnormal postures, abnormal reflexes, and abnormal muscle performance and tone. Children with all forms of CP will also manifest sensory problems, speech disorders. They may have attention deficit disorder or some level of autism, cognitive challenges, and recurrent seizures. That's why any episode of possible anoxia during prenatal life or at birth should be documented. These children need careful neurologic assessment during the first year of life so that small signs of impairment can be tracked and child can be monitored closely for further testing and assessment. Tests. A skull radiograph or ultrasound may show cerebral asymmetry, however, the skull shape usually is normal. A CT scan or MRI is usually negative, and the EEG also may be abnormal from a spike of seizure discharge. For long-term care, Children with CP must be cared so they may reach their fullest potential within the limits of their disorder. It's important to teach parents to care for a child with chronic illness, and with such, we can also listen to them as they express their emotions. They may also grieve because their child is not able to accomplish a lot of things, and they may feel the everyday stress of caring for a child with multiple special needs. Tests, a skull radiograph or ultrasound may show cerebral asymmetry. However, the skull shape is usually normal. A CT or MRI scan is usually negative, and the EEG may be abnormal from a spike of a seizure discharge. For long-term care, children with CP must be cared so they may reach their fullest potential within the limits of their disorder. It's also important to teach parents that they will care for a child with chronic illness, and it's important to listen to them as they express their emotions. These parents may also grieve because their child is not able to accomplish a lot of things, and they may also feel the everyday stress of caring for a child with multiple special needs. Meningitis is the inflammation of the meninges of the brain and spinal cord caused by bacteria such as Streptococcus pneumoniae, Group B Streptococcus, E. coli, Pseudomonas, or Haemophilus influenzae. These pathologic organisms usually spread to the meninges from upper respiratory tract infections through the lymphatic system, mastoid bone or sinuses, or by direct introduction through lumbar or skull fracture. Once organisms enter the meningeal space, they multiply rapidly and spread throughout the CSF and brain, and they cause inflammation. The symptoms of meningitis occur either insidiously or suddenly. There are 4 general signs of irritation. The pictures show them: nuchal rigidity, stiff neck. Brudzinski's sign is the flexion of the hip and the knee in response to forward flexion of neck. Koenig's sign is the contraction and pain in hamstring muscles when attempting to extend leg when hip is flexed, and the opisthotonous position is when head and heels are bent backward and the body is arched forward. Aside from these meningeal signs of irritation, there are other signs seen in meningitis as well, such as a child is irritable because of headache. There could be febrile seizures, cranial nerve paralysis. The fontanelles, if they are open, they are bulging and tense. If they are closed, the fontanelles can cause papil edema. There could also be septic arthritis, petechiae. There's poor sucking, a child has weak cry, and there is lethargy. Diagnosis: 1 is through CSF analysis by lumbar puncture. Its results show increased WBC and protein and decreased glucose. Blood culture can also reveal the causative bacteria. A tuberculin skin test can also rule out TB meningitis. A CT scan, MRI, or ultrasound can check if there are already abscess and the ICP result is severely elevated. As a management, a large doses of antibiotics given IV or intrathecal injections are directly into the CSF. By the way, this intrathecal injection may be necessary because the blood-brain barrier may prevent an antibiotic from passing freely into the CSF. These antibiotics should have been indicated by sensitivity studies. It's given 8 to 10 days or as necessary. Examples are ampicillin, cefotaxime, ceftriaxone. These antibiotics may also be prescribed prophylactically to family members or others who have been in close contact with a child. Second are giving of corticosteroids or osmotic diuretics to reduce ICP, and this can also help prevent hearing loss. Corticosteroids such as dexamethasone or osmotic diuretics such as mannitol. Third is place child on respiratory precautions first for the first 24 hours after the start of antibiotic therapy. This is to prevent transmission of infection as meningitis is highly contagious. Meningitis is always a serious disorder because it is fatal. However, if symptoms are recognized early and treatment is effective, a child will recover with no sequela. But if ever the possible neurologic sequela are learning problems, seizures, hearing difficulties, and cognitive challenges. Guillain-Barre syndrome is also called inflammatory polyradiculoneuropathy. It's a perplexing syndrome that involves both motor and sensory portions of peripheral nerves. The inflammation of the nerve fibers causes temporary demyelinization of the nerve sheaths. In the photo, you will see that the peripheral nerve fibers have damaged myelin. Myelin sheaths, as a review, forms around nerves and allows electrical impulses to transmit quickly and efficiently along the nerve cells. This condition affects both sexes and occurs most often in school-aged children and adolescents. Cause is relatively unknown, but it is suspected that the reaction is immune-mediated, occurring after an upper respiratory tract or GI illnesses or immunizations. Symptoms appear in the following order. Remember that Guillain-Barre syndrome symptoms appear as ascending and symmetric paralysis. Children would usually experience peripheral neuritis several days after primary infection, and then there would be decrease to absent deep tendon reflexes. Second, muscle paralysis and paresthesia begin first in the legs, and then they spread to involve the arms, trunk, and the head. Again, they are of ascending nature. Third, facial weakness and difficulty in swallowing occurs. The last is when this person really needs intensive care, when the respiratory muscles become involved, as spontaneous respirations are no longer possible and warrants mechanical ventilation. A significant laboratory finding is an elevated CSF protein level. An EEG may also show that there is denervation and decreased nerve conduction velocity. For the management, prednisone can be given to halt the autoimmune response. If with discomfort because of neuritis, mild analgesia can also be given. Plasmapheresis or transfusion of immune serum globulin may shorten the course of the illness. It's important also to prevent all the effects of extreme immobility through passive ROM, turning and repositioning frequently. Most importantly, we guard the cardiac and respiratory function using ventilators, and this requires an ICU care. Also, an indwelling urinary catheter can be inserted to monitor urine output, and the enteral or parenteral nutrition to support protein and carbohydrate needs. Treatment of Guillain-Barre syndrome, as you can see, is supportive until the process runs its course. Paralysis usually peaks at 3 weeks and then it is followed by gradual recovery. Fortunately, most children recover completely without any residual effects of the syndrome, although they may continue to have minor problems such as residual weakness. But other than that, Guillain-Barre syndrome children recover well. Bell's palsy or facial palsy is facial paralysis of the seventh cranial nerve. That's the facial nerve. It's the nerve that innervates the muscles of the facial expression. The syndrome occurs abruptly. It usually happens after a herpes or a Lyme disease infection. For the assessment findings, please take note that all these are happening all on one side of the face. There's droopy eyelid, inability to close eyes, dry eye, or excessive tears. There's also facial paralysis, sagging face, twitching, or weakness on one side of the face. There's also drooping corner of mouth. There could be dry mouth or impaired taste. For the management, therapy consists of prednisone to reduce inflammation and acyclovir if the syndrome appears to be from herpes. If the child is unable to close the eye on the affected side, eye drops 3 to 4 times daily will be needed. The child can also have that affected eye covered. Although recovery is slow, usually not until 4 months, most children recover without any permanent disability. Seizures are involuntary contraction of muscles caused by abnormal electrical brain discharges. It is beyond voluntary control, produced by excess neuronal discharge due to an abnormal electrical activity of the brain. Approximately 2 to 3% of children will have at least one seizure by the time they reach adulthood. Epilepsy is a chronic recurrent seizure, but now the preferred term is recurrent seizure because epilepsy carries the stigma of cognitive challenges and behavioral disorders. Febrile seizures, on the other hand, is associated with high fever common among preschools. Because these seizures arise with high fever, they are largely preventable. It's important to give acetaminophen to keep fever below 38.4. Beyond that temperature, there's a high risk for febrile seizure. Status epilepticus refers to a seizure that lasts continuously for longer than 30 minutes, or it could be a series of seizures from which the child does not return to the previous or the normal level of consciousness. This is an emergency situation requiring immediate treatment. Otherwise, exhaustion, respiratory failure, permanent brain injury, or even death may occur. There are several causes of seizures: idiopathic, familial or inherited, or could be from an infection, trauma in the brain, or tumor growth in the brain. But among all these, almost half of seizures are unexplained or from idiopathic causes. There are also major categories of seizures. Partial would involve only one area of the brain, while generalized seizures involves the entire brain and loss of consciousness usually occurs. Box 49.5 shows the classification of seizures, whether partial or generalized. Please review each one. Management. During a seizure, priority is to protect the child from injury and keep the airway open. You can probably put the child in a flat surface, free from any injury, and protect the head. After a seizure, place the child in a side-lying position to allow secretions to drain if there are any. You have to stay with the child. He or she might feel very sleepy or tired after a seizure attack. Third are drug therapies such as carbamazepine, phenobarbital, phenytoin, valproic acid, diazepam, or lorazepam. These anticonvulsant drugs help prevent another seizure attack. Review these anticonvulsants, their indications, their action, as well as their side effects. Fourth is to treat the underlying cause of seizure if identified, such as if it is caused by an infection or a tumor, antibiotics for infection, or surgery for tumor.